The Pharmcast is a podcast sponsored by the Maryland Pharmacists Association. I'm your host, Aaliyah Horton. I'm the Executive Director of MPHA. And in my role, I have the opportunity to meet so many fascinating people within Maryland and around the country that are engaged in the practice of pharmacy. They're stakeholders, they're innovators, collaborators, and advocates. And this is my opportunity to bring those conversations and experiences to you. And it's another way that MPHA is fulfilling its mission to strengthen the profession of pharmacy, advocate for pharmacists, and to promote excellence in pharmacy practice. My hope is that at the end of these conversations, you will leave informed, engaged, and connected to pharmacy and our Maryland pharmacy community. Thank you to our advertiser, Value Drug Company. Value Drug is a full-line pharmaceutical wholesale purchasing cooperative located in Duncansville, Pennsylvania. They distribute specialty medications, pharmaceuticals, and non-prescription medications, hospital and convalescent equipment, health and beauty aids, nutritional supplies, and other healthcare-related products to member retail, long-term care, specialty pharmacy, and 340B covered entities. Please sure to call Lisa Steptoe at 443-324-1031. Thank you again, Value Drug. Hi, welcome to the Pharmcast. Today's episode is all about PBMs, pharmacy benefit managers, for those of you who don't know, but I think most of the people that are listening to this podcast and watching know about PBMs, but there's always something changing. Sometimes it gets worse. Sometimes we have some bright spots. And so today I'm here with Antonio Ciaccia from 3 Axis Advisors, whom I met actually when he was working with the Ohio Pharmacists Association and really took a deep dive into PBMs and really kind of spearheaded the work that the Ohio Pharmacists Association and pushed the Ohio Insurance Commission, Department of Medicaid, all of those folks to really make some changes in Ohio on PBMs and continue to do work. We see great reporting out of the Ohio, I forget the name of the newspaper.
The Columbus Dispatch.
The Columbus Dispatch has been doing great reporting for years. And so all of us around the country really take those reports and pull pieces out of it and use it as, honestly, a strategy for what's happening in our state. So you and I have done at least one radio show together talking about these issues, but I heard in the fall that 3 Axis Advisors had done this new report called Unraveling the Drug Pricing Game. And there were really some eye-opening pieces of information that came out of that as much as, we're involved in this topic, it ceases to amaze that, like, you always end up coming out after a new report with something else that's shocking. And the big thing that jumped out at me was that when a person goes into the pharmacy, there was one particular drug, I think there were 117 different pricing schemes for that one drug. So can you talk a little bit about the report and just share some highlights from that? Because it was just eye-opening.
Yeah, so I'm inquisitive by nature. Drug pricing is really a tale of many experiences for anybody that's engaging within the drug supply chain, dating back to when I worked as a pharmacy technician, in high school, right? I didn't think about it a lot at the time, but I always found it was interesting in retrospect that a patient would walk up and get a drug and it'd be a $0 copay. The next one could walk up and it's $10. The next one could be $20. And the next one could be $150, right? Mm-hmm. So, and it could be the same drug oftentimes. So by background, we helped uncover a lot of the ways that PBMs are taking advantage of drug pricing by exhausting our time, saturating ourselves in data to see what is the actual cost of medicines, how are pharmacies being compensated, and how are plan sponsors or payers like Medicaid programs being charged for those same drugs. Well, what we did in our latest report is we worked with the American Pharmacy Cooperative Incorporated, APCI. They're like an independent pharmacy buying group or cooperative. Mm-hmm. And we've done a few reports with them where we examine how PBMs are setting prices from a pharmacy's experience. Well, with this report, we asked the question, okay, well, if everybody's complaining about drug pricing, my bet is a lot of the people that are complaining from a policy perspective and from a media perspective are approaching this from the angle that the prices that patients are paying are too unaffordable and we need to do something about that. So we set out to ask in this report was to say, using pharmacy data collected from all over the country, 35 different states, over 1,500 different pharmacies, we just asked, hey, how is the price being calculated at the pharmacy counter? Is it the manufacturer's price? Is it the pharmacy's price? Or is it something else? Is the PBM inventing the price? And so we said in this report called Unraveling the Drug Pricing Blame Game, we simply asked the question, who is creating the price that is experienced at the point of sale? How does it impact the pharmacy? But how does it also impact the patient? And what we found was that when you dig into pharmacy claims data, there are certain standards with which we transact claims in pharmacy, and all of that is governed by NCPDP. And so what it creates is essentially a universal language that binds every aspect of the claims transaction together. And one of those fields is called the basis of reimbursement, which is what the PBM will volunteer, they have to put it in the actual claims data to say, this is how we are arriving at price. Mm-hmm. And when you look at that field, that single field, you'll see that there are over 20 different ways that a PBM can label what the basis of reimbursement is. And so as we analyze the different methods that were used to create the basis of pharmacy reimbursement, we found that overwhelmingly subjective PBM created prices were what yielded the end price at the point of sale. And so we're talking about this now as if it's a pharmacy reimbursement issue, but we have to then ask the question of how are pharmacies ultimately compensated for dispensing drugs? And the truth is there are two inputs. One is what the PBM is inputting, and the second is what the patient is inputting. So between the patient's copays and what the PBM is paying, those two things together will create the pharmacy's overall reimbursement picture. So that's what we were looking at. The important thing to pull from that, though, is that if the PBM is setting the prices in many disparate different ways, that ultimately is going to impact the amounts that the patient is investing in that transaction as well.
And what were the results? Can you talk about the one with the 117? Like, I understand you got these different inputs, and when you look at that, that's one drug that if you take the drug manufacturer's price, the drug manufacturer has one price, right?
That's right. Yeah, so this is the best part of this, is because I love my folks that in journalism that are reporting on what's happening in the drug supply chain, right? But one of the things that has frustrated me over time is that when we talk about drug pricing in a holistic sense, right? Typically what we do is we say, well, the manufacturer is bad because they set the price too high, or the pharmacy, they're bad because they set the price too high, right? Well, in actuality, what we see is that regardless of what the manufacturer does, and regardless of what the pharmacy does, the PBM is inventing what the reality will be at the point of sale. They ultimately will determine how much the pharmacy will be paid. They will determine how much to bill the plan sponsor, and they will determine how much the patient will pay in cost sharing. So to give you an example of how PBMs are setting out to set prices in the drug supply chain, we found some drugs where it could be the same manufacturer making the same national drug code. So for those that know pharmacy or don't know pharmacy, the National Drug Code, or NDC, think of it as the social security number for an individual drug, right? Mm-hmm. It is an individual drug made by a singular drug manufacturer, same strength, there's nothing different from one version to another because it is all from the same supply, right? Same packaging. We found the same drug being priced very different ways from pharmacy to pharmacy, or even patient to patient. We had one drug, it was duloxetine, where we had one PBM, it was the largest PBM in our data set. They had priced the same NDC for duloxetine 5 different ways on the same day at the exact same pharmacy. And the pricing wasn't just off by a couple pennies. The lowest charge was over $9 per prescription, going all the way up to $96 per prescription. Again, same drug, same manufacturer, same list price, same pharmacy usual and customary price, same strength, same package size, very different prices. And so without saying, hey, what the PBM is doing is bad or good, what we are saying is that if we care about affordability from a patient perspective, if we care about equity from a pharmacy treatment, how PBMs subjectively determine the prices of medicines when paying pharmacies and billing patients and plan sponsors, those things are going to be a material thing to infuse into the discourse if we want to really drill down and ask the question, are drugs priced reasonably or not?
Yeah. And when you look at the information that you have here, and many of the states have been working to do PBM reforms to figure out a way to support the pharmacies practicing in different communities, as well as ensuring that patients have access to medications. We've seen legislation that's been passed. It's like piecemeal, it's here, there, but we've never gotten anything sort of comprehensive. And I've been hearing a lot about this DIR fee cliff that's coming, plus the Medicare reimbursement rates for 2024. What are you seeing, and what is that impact going to be if the states, the federal government, if they don't act quickly on addressing these issues and streamlining them and getting something consistent that everyone can understand?
Well, I think sometimes policies at the state and federal level come up short because there's just aggressive lobbying that's being done on the other side that I think is tough to overcome. Without saying, what policies are necessarily good or bad, let's just say for the sake of this discussion that there are a lot of interests in calibrating what PBM legislation looks like, right? Pharmacists would like to be treated better. Patients would like to be treated better. Plan sponsors would like to be treated better. Health insurance companies would like to be treated better. Manufacturers would like to be treated better, right? Every stakeholder is influencing what end policies will look like. And sometimes, certain constituencies will win versus others. And the degree of that win will be, large, small, et cetera. But usually what I see is that because drug pricing is so complex and convoluted, what usually ends up happening is let's say a pharmacy group says, if you pass this policy, it will save money. But on the other end, the PBMs will come in and say, if you pass this policy, it will cost money. The truth is that many of the stakeholders that are operating on both ends of that spectrum may not necessarily have enough information to be saying with conviction that either side is correct, right? So there is, and not to say that either side is lying, but I think it's very hard for a policymaker to act on partial information, which we are all operating with partial information to a degree, and I'll explain. What do we always call PBMs, and what do we always call drug pricing? We call it a black box, right? And that is because a lot of the proprietary details of where money goes in the drug supply chain at every layer is proprietary and considered under lock and key by many. And so many stakeholders have a vested interest in not disclosing really where the true financials are when it comes to particular claims transactions. Whether that's a good thing or a bad thing, what it does mean is that we're often under-equipped to adequately say where a certain policy will save money or not. So because we're not always operating with a full deck of cards, we have to operate with the cards that we do have. And so from my perspective, we've seen a lot of policies where we have enough cards on the table to be able to appropriately infer whether or not a certain policy will at least yield better incentives for savings or yield real savings. Oftentimes what we hear on the other end of the argument, which is if you do X, Y, and Z, it will raise premiums. Oftentimes you are given, again, a very curated view of the world, or a very limited number of cards are put on the table to be able to convey, what it is the policy would actually yield. So without saying, whether one side is bad or good, what I am trying to say is that oftentimes, because we're not operating with that full deck of cards, a lot of policymakers lack conviction and self-esteem in passing any particular policy. So oftentimes, a piece of policy that might be promising for maybe protecting patients, pharmacies, health plans, whatever it is, right?
Mm-hmm.
Oftentimes it will come up short because there will be such a large cloud of smoke around whether or not the policy will be in fact good or bad. That's why we try to do whatever we can to simplify drug pricing, such that, if you're a policymaker or you're a plan sponsor, you should be able to operate in a marketplace where you don't have to rely on nerds like ourselves who are obsessed with drug pricing and still don't have all the answers, right? I believe drug pricing should be straightforward enough that a layperson operating an HR department or a patient that has no experience with drug pricing can have enough information and enough conviction to navigate the marketplace in such a way that they don't feel like they're going to get ripped off.
Mm-hmm. Yeah, I think that's, you bring that up. And one of the things that we've noticed over the last, I would say, year and a half, as we've had these conversations, and as you said, there are various stakeholders, they're influencing how the legislation is getting passed, and we're all trying to figure out a way to meet the needs of our constituencies, obviously. But one of the groups that I feel like has gotten pulled in, caught in the middle, but also a little bit on the wrong side, I'm just going to say, is the chambers of commerce. The PBMs have really started joining local, state, regional chambers of commerce and saying, oh, if there are reforms, this is going to make your prices higher, this is going to impact you all. And they're not really getting the full picture of what that negotiation is, what those contracts are. So they're coming out in support of the PBMs and the role that they're playing, not realizing that a lot of their employees, the people that they're representing, that they're trying to support having healthcare, that they're limiting their access because of the impact that's on the pharmacies in the state. I don't know what your thoughts are on that kind of change in stakeholders and strategy.
Well, it's important to remember that the National Chamber of Commerce doesn't represent business unilaterally across the board. It represents big business. The membership size of the U.S. Chamber of Commerce has dwindled significantly over the years, but its actual revenue has grown. That's a reflection of broader market concentration, but also a broader concentration of the U.S. Chamber of Commerce membership. That is an inherently bad thing. It doesn't mean that they're necessarily compromised, although they do have obvious conflicts of interest because of support that they've gotten from health plans and PBMs over time. But let's just put that off to the side, right? Mm-hmm. Not saying it doesn't matter, but let's just give them the benefit of the doubt and say that they're truly trying to advocate for their members and not just a certain constituency within it. Well, what we have in the drug supply chain is a series of leveraged experiences, meaning that we don't live in a world that pays for medicine based upon its value. We buy medicines through volume-based, leveraged, discounted contracts, meaning that the bigger you are, the bigger negotiation or the leverage you have in a negotiation, and the better discounts you can get. That's why the largest PBMs in the marketplace today are successful in getting the biggest discounts from drug manufacturers. Now, they very rarely pass along all those discounts, mm-hmm. and they end up inflating the prices of medicine because of that dynamic. But it goes without saying that the largest PBMs, because of their size and scale and sophistication, are able to leverage bigger discounts than maybe their smaller PBM competitors. Mm-hmm. The same is true in the plan sponsor world. The larger and more sophisticated the plan sponsor is, the more likely it is that they'll be able to get lower or bigger discounts off their medicines from their PBMs. The truth is that the drug supply chain makes money off everybody, right? But they're going to make it in different degrees off of different ends of a spectrum. Yeah. There's the largest and most sophisticated buyers who we can say in pencil, right? They're going to get better deals than those that are in the middle. And then there's the other end of the spectrum that's just getting absolutely trampled over. Mm-hmm. So if we believe that train of thought, right, then it stands to reason that the largest plan sponsors in the country are going to be large businesses who will have, again, disproportionate representation in the and influence over the U.S. Chamber of Commerce. That same thing trickles down to the state level, where we see, again, more big businesses that are involved in the chambers of commerce at the state level, but not necessarily reflecting the interests of smaller businesses, which is why you have groups like the local chambers of commerce, which in my experience are more small business focused. You have organizations like NFIB as well. In my experience, employers are afraid of PBM reform, not because they like PBMs, but because they genuinely don't know what to think of a particular policy and whether or not it will positively impact them. Usually all they have to go on is what their health insurance company, their PBM, and their consultant who's paid by the health insurance company and PBM, usually they're the ones that are influencing the opinions of employers when all of a sudden a policy gets proposed and all of a sudden, the PBMs and the health plans and then their benefits consultants come in and say, this will raise premiums, whether or not it actually does or not. The employers will take their cues and say, well, I don't want my premiums to go up, so we're opposed.
So, right. Yeah, and I was just thinking about that, just kind of drilling it down to more of the regional level. I was actually in the grocery store yesterday and ran into one of my son's teachers, and she was asking about, hey, what's going on with the pharmacies? I heard that this chain is closing down a number of pharmacies in our community. We don't know where we're supposed to go. Why are they doing this? And I kind of had to, in the grocery store aisle, break it down a little bit. But I think one of the things that has come up, a question that keeps coming up, is if one of the larger chains is an insurance company, a PBM, and a brick and mortar pharmacy, and they have, because of that vertical integration, they have some control over or what they're doing and how it impacts the pharmacy. How are they having so many challenges and closing stores? Like, what's the end goal for that? I have my thoughts on that, but I was wondering what you think about that and strategy there. Like, how is that helping what they're supposed to be doing, which you would think is healthcare, community access, and that sort of thing?
Well, first and foremost, if you want to explain something to somebody at the grocery store, you pull the box of Cheerios off the shelf and you say, hey, the price tag here says $5. If you want to know why pharmacy access is dwindling, think of this box of Cheerios as a metaphor for what everything is at the pharmacy counter at this point. Imagine a pharmacy has to sell this box of Cheerios or the grocery store, a box of Cheerios for $4.50 or $4, right? Yet they acquired it for around $5. That's what's happening in pharmacy. And the reason that you're seeing access deplete is that we don't actually pay pharmacies in a straightforward, rational approach. The study that we just released in previous that we've shown is that pharmacies lose money on a lot of claims. All right. They make some money on some claims, but not enough to break even. But then they can make a ton of money on some other claims. And so some pharmacies, when you add it all together, they're doing well. When other pharmacies, you add it all up, they're doing poorly and they go out of business. So you have the system that doesn't reward pharmacies based upon how good they are or how the quality with which they deliver care to patients. It's a casino. And some pharmacies win because they have a disproportionately beneficial share of prescriptions that PBMs have decided to favor relative to others. Our research, unfortunately, shows is that the pharmacies that end up getting the shortest end of the stick tend to be pharmacies that are operating in the most underserved and poorer communities. So we're seeing access dwindle in certain parts of states and flourish actually in other states. The thing that we see consistently across the board, though, is the pharmacies that are owned by the PBMs are typically doing the best, whereas smaller regional chains, independent pharmacies are typically doing the worst. That's one thing, all right? But on the other side of what you were asking is, how is this dwindling of pharmacy access consistent with a broader public health approach and consistent with the supposed missions of the large vertically integrated healthcare companies that are running this entire marketplace at this point? And the truth is, I think we just have to be honest about it, is that these are not healthcare companies. I think that we should look at all publicly traded companies as what they are, publicly traded companies that are in the business of making more money, regardless of how they make it. That's not to say that they don't have ethics or morals or anything like that. We just have to understand that publicly traded companies have a fiduciary obligation to shareholders. That what that means is that their number one priority has to be returns to shareholders. When you and I invest, in our retirement funds, if we even have any, or what little we do have, right? We want to hopefully invest with folks that have the best returns because we want better retirement. Nobody says to their broker or their anybody who advises them on investing to say, I would like something with somewhat good returns, right? We want to get the most out of our money. And that is what the stock market is designed to do, is to create a system where the incentives yield, hopefully, the most amount of returns on investment. Whether we like that or not, that's reality. And so whether we're talking about drug companies or PBMs or health insurance companies or publicly traded pharmacies, right? Assume that their number one priority is going to be greater returns on investment today than they had tomorrow, and hopefully they do better than the next day, right? It's about making more money. And so when you view it through that lens, which I understand sounds pessimistic, but the things that are happening in this system start to make a lot more sense, right? If I'm not making a lot of money at a certain pharmacy, close it, right? Regardless of how that impacts the community. If I'm not making money dispensing a certain type of drug, stop stocking the drug, right? And let's not throw all the shade on just the publicly traded companies, right? Other pharmacies can do this too. Everybody has different incentives, different ethics, different morals. But the difference between a publicly traded company is they have to do that, whereas other smaller independent businesses, they don't have to, they're just incentivized to. So this is where I bring it back to policy, right? Understanding the influences and incentives of both private businesses and publicly traded businesses who, left to their own devices, we should trust want to make more money. Then from a policy perspective, if we want to achieve better public health, then we need to build policy in mind to frame the incentives in the direction we want them to be in, or curtail the ones that we don't want to exist in the first place. Instead, we're always constantly tweaking around the edges and then wondering at the end of it, why is this system still broken? Well, because we haven't done a sufficient job of actually changing the fundamental incentives that drive and reward behavior in the drug channel.
I love that line of thought. That might show up in some testimony. So just letting you know that now. I just had two last questions. And so one is you've talked about this. I feel like it leads into this line of questioning about the workforce conditions and the impact of all of this on workforce conditions in pharmacies. And I think when you talk about framing the incentives and curtailing the bad ones, I would like to think that we can frame the conversation with future legislators about this is where some of the incentives are to reimburse pharmacies appropriately, to have affordable medications, incentivize community health care and community access, and curtail the issues that cut that away. And part of that is creating the challenges that we have in the pharmacy workplaces, in community pharmacies. And we know when you're talking about where the incentives are, all of the pharmacies are having these challenges, whether they're chain or independent pharmacies, with the reimbursement issues. But the workforce conditions are very different. And I believe it's because they are beholden to different entities in many cases. And so there's that challenge there. But could you talk a little bit about, I know I was a little rambling a little bit, but could you talk a little bit about your thoughts on the workforce conditions, and if the work that you're doing can help impact that, or any insight on how we can approach it?
First and foremost, we have a good idea of the average cost that it takes for a pharmacy to fill a prescription and break even. There are cost dispensing surveys that are done across the country by state Medicaid programs. NACDS and NCPA used to do one as well. It generally will show that, for ballpark's sake, right, the average cost for a pharmacy to fill a prescription can range anywhere from $7 all the way up to $15. right? We could argue over that range a little bit. We could say what's fair, what's not. But in general, let's just, for conversation's sake, say it's around that range. Well, PBMs aren't paying that much, right? They're not paying that much in dispensing fees. Certainly, sometimes there's enough margin built in the underlying ingredient cost of the drug for the pharmacy to make some money. But in general, I can tell you, I've looked at a lot of pharmacy books. That's not what they're making. And so, from a value perspective, PBMs have not put a value on what pharmacists do relative to the actual cost to perform that service. So understandably, that's going to create a lot of pressure in pharmacy to, cut corners where you can from a financial perspective. I think it's also really important to point out, I've been in a lot of long-range strategic planning meetings for different pharmacy organizations over the years. I can tell you the one thing that almost comes up usually on day 2 of those meetings is, what we need to do? We need to come up with an attribution model for pharmacies, right? I hear this all the time. Mm-hmm. We know that the busy pharmacy, all right, that's filling 2,000 prescriptions with, a pharmacist and 2 techs, right? We know that pharmacy is going to do a worse job than the pharmacy that has 3 techs, a pharmacist with some overlap, and 500 prescriptions, right? I'm just throwing out numbers here, right?
Yeah.
But an understaffed pharmacy is an ineffective pharmacy from my perspective, but it is a very efficient pharmacy. So the question is, what do we want from drug pricing? Do we want cheaper drugs, or do we want higher quality drugs and higher quality service? Or do we want both? If you held us down, we'd say we want both, but when it came time to pay the bill, we want efficiency, right?
Mm-hmm.
And so in the current model, we want volume. Again, we don't pay for value, we pay for volume. And in fairness to the payers, we in pharmacy have failed at demonstrating what the value of a well-staffed, high-quality, staff pharmacy is versus another. So as a result, the end payer doesn't recognize that value. And as such, all they left with nothing, with no other information, they say, I would like to pay less, please. Mm-hmm. And so you see that pressure. It all pushes down to the pharmacy. Well, the part of the problem here is that eventually understaffing has its drawbacks from a consumer perspective. Look what's happening in Ohio right now. CVS is being hauled before the Board of Pharmacy for allegations of major issues in quality, safety, and staffing, okay? And let's be clear, CVS is not the only party here that has challenges there, but they're the ones that are getting the headlines. So sorry, CVS.
I just read that article.
Yeah. And it's, to me, the things that we're seeing in the reports are an embarrassment to the profession, right? Again, those problems are not exclusive to CVS. They happen in pharmacies of all shapes and sizes over time, but we're seeing a more consistent trend within them in the state of Ohio in a number of locations. All right. If I was a patient, all right, and the pharmacy that I went to had a month-long wait, which is exactly what one of the pharmacies here in Ohio is having, I'd go somewhere else, right? I wouldn't go to that pharmacy. But because we don't have meaningful consumer power, because the PBM is the one negotiating on our behalf, the PBM is telling us which pharmacy we can and can't go to.
Or you have to go to mail order.
Yeah, and the PBM could say you have to use mail order, right?
Right.
I, the consumer, I have a constrained amount of choice in this marketplace. If this was grocery stores and the line was out the door to go check out on a consistent basis, I would no longer go to that grocery store. I would go somewhere else.
Right.
So what happens at the grocery store? Competition makes sure that maybe outside of peak hours, there's sobriety to the amount of time you'll have to wait to go check out. There's a consistent supply of things on the shelves, et cetera. You can find people to help you. But in a system where you, the consumer, doesn't have a meaningful impact on what is ultimately produced by a retailer, well, this is what you get. You get bad staffing, bad quality, bad service, all of those things. And all of that is because, or a lot of that is because we, the consumer, are not the ones impacting what the retailer is providing. It's the PBM. That's where all the incentives are. So I think a lot of pharmacists are quick to say, well, understaffing, it only happens because the PBMs are underpaying. I want to be very clear. the PBMs are underpaying in a lot of instances, and they're creating a lot of the pressure that is yielding to understaffing. But also, let's not pretend if we paid every pharmacy $20 above the cost of the drugs, the same pharmacies that are in trouble with boards of pharmacy for understaffing wouldn't have a lot of those same problems moving forward, because they already learned that they could get away with it in the current world, and they'll know that they could get away with it in the next world and make more money that they could turn back to those shareholders. So to me, it's a question of how do we want to govern the practice of pharmacy? Are there things that boards of pharmacy can do that can raise the bar, right? Whether that's through enforcement of current rules and laws or putting new ones on the books. To me, what I want to see is a system of incentives that rewards pharmacies who spend extra time with patients and actually impact that patient to a better outcome. Most pharmacies hear that and say, oh God, don't give me more DIR fees, right? But at the end of the day, what I strive for is, I believe that there are many pharmacists, not pharmacies, pharmacists who are high quality healthcare professionals who can have a meaningful impact on not just the patient experience at the pharmacy counter, but in their broader healthcare goals and well-being.
100%.
I believe that the current system does not reward those pharmacists for the quality work that they do, because they're not recognized as providers and they're not treated as anything other than a glorified, pill pusher, financially speaking. And that has to change, because there are bad pharmacists out there who are doing the minimum, whether it's because they're understaffed and they're put in a position of failure, or because they're just not good pharmacists, right? There are bad apples in every profession. We don't incentivize the good behavior. We don't reward the good behavior. And instead, we treat every pharmacy essentially as the same, except we don't, because the PBM chooses to overpay or underpay based upon the subjectivity and chance of different prescriptions getting dispensed versus others. So we have to move away from the current model of payment and create incentives that reward those who do well. On the flip side, that punishes those who are doing poorly. And I believe that the pharmacies that staff well and do right by their patients will demonstrate better outcomes and better value, and thus should be rewarded financially.
Yeah. Now, is there any state or anywhere that you think that has gotten it right so far, or is on a pathway to heading in that direction?
So this is my belief, is that we have to standardize the way that we compensate pharmacies. So we can't have a system that underpays and overpays for certain medicines with no real meaning behind it, right? So a pharmacy shouldn't be saddled with an underpayment for lisinopril and an overpayment for generic Gleevec, unless we intend for that to be the outcome, right? I live in a world where I believe that every patient that walks through the door should be treated equally. So we should incentivize equally across that continuum. And if we want a higher service or a higher value of the from what the pharmacist can offer, we intentionally build that into the payment model when we choose to do so. So as an example, we started this with MTM, right? We started to add increased compensation for types of counselings and things like that and interventions. But in the current world, you can see MTM might pay, let's just say $25, $30, $40, depending on the type of intervention. If I fill a prescription for generic Gleevec in most states across the country today, I can make $3,000 in profit on that single prescription, okay? Now, is the pharmacist offering $3,000 of value there? Far be it for me to say. But when I know that the break-even point for a pharmacist is around $7 to $15, and then there's a $3,000 profit, I'm going to go on a limb and say, we're way overvaluing the dispensing of generic Gleevec. All right. So if I'm a pharmacist, I could, do a ton of MTMs and invest a ton of time and energy and doing those, and I might make $3,000, but look at how many man hours I'd have to invest to achieve it.
Right.
Or I could dispense one generic Gleevec prescription and wipe it all out. So I argue for this new payment model, not because, hey, I want to pay pharmacists more or less. I want a better approach to the philosophy of how we pay pharmacists. I believe very much in cost plus modeling or NADAC based or AAC based or any sort of accurate representation of the underlying cost of the drug, plus a set fixed dispensing fee over top of that. At that point, you're creating a foundation of cement, if you will, an equitable incentive system from drug to drug to drug. And if the pharmacy wants to make more money, ideally what we're having them do is provide something beyond the fill, right?
Right.
Whether that's an MTM, whether that's opening up clinical services and being billed as a medical provider, whether that's delivering a drug to a patient, immunizing, administering a drug, spending extra time with that patient or their doctor, right? Those are all things we want, but we don't pay for typically. And so I want to build a system where we create cement on cement over the cost of the drug and the dispensing of the drug, again, without telling you how much to pay over top the cost of the drug, but as a philosophy. And then you build the other incentives
pieces.
On top of that.
Yeah, I'm very happy to say that in Maryland, we did pass provider status, and pharmacists can bill under medical codes for anything within their scope of practice. So we got the bill passed. Now what we're working on is the implementation to get people up to speed, to get the payers online, and so that we're not having lots of different ways that they're credentialing and doing all that, but setting up a standard so that it's clear across the profession on how they can go about doing that. So that is one of our big strategic initiatives. So I'm happy to mention that we're making steps forward. It's never an easy process, particularly changing that mindset of having payers as well as legislators really understanding that difference between dispensing and providing clinical services, and the combination of the two really provide the highest level of health outcomes. So thumbs up for MPHA on that.
Congratulations. That's exactly where we need to go, right? There are some pharmacists who I think are look at provider status with somewhat of a glass half empty perspective. And I understand that, because there are many pharmacists who have sat there for 15, 20 years and say, what I used to do used to be viable, and now it's not. We shouldn't just have to jump to another lily pad in order to make the business model work, right? The old business model should work. And I agree with that sentiment. But we have to understand that even under the old model that was perhaps, still viable, is this underlying issue that we don't have incentives that reward pharmacists who go above and beyond for the patient, right? We want to incentivize better pharmacy care. And so in the old model, we didn't really do that, right? The only way that we were rewarded in the old model, and this is going even further back pre-PBM, is that more patients would go to the pharmacy that took care of them, right? They would bring their business to the pharmacist that would do better for them. Well, today, patients have been removed from their position of power in the marketplace for the most part. So as such, health plans and PBMs are really the kingmakers. Well, I think there are opportunities there, and a lot of the logos that many pharmacists will view as villainous could actually be somewhat of our saviors at some point. I mean, back in Ohio, after we passed provider status, we had substantive, legitimate, real conversations with folks like United Healthcare, Molina, Centene, CareSource, Anthem, all health plans that drive pharmacists nuts on the drug product payment side. But think of it from their perspective, they have incentives too, some of them not very healthy, right? But in some aspects, they also need to make sure that they're ultimately taking care of that patient. They have to pay for certain medical services in an increasingly consolidated and expensive hospital world, right?
Right.
If pharmacists can start offering service closer to home at a high quality level at a reasonable price, it can save them a bunch of money on the hospital side and medical benefit side, while paying pharmacists, much better than they're usually accustomed to, right? There's so much fat on the medical benefit. I think pharmacists can provide a substantial opportunity to save money on the medical benefit while helping to transition the business model a tad and reward those pharmacies that are going above and beyond for their patients.
Yeah, and we had a program where we work collaboratively with the University of Maryland School of Pharmacy on a program that does MTM and other things for self-insured employers. And we had one huge contract that went so well that they stopped the contract and just hired the pharmacist to work for them.
Awesome.
So yeah, it was fantastic. Not so great for the program. We're still trying to build that out, but I think for what you're talking about, that value was definitely seen, understood, and invested in. So with
And this is
that,
what CPSN is trying to do, right? This is what
yes,
NCPA and CPSN networks are
yes, yes,
are striving for, right? And so I do see an opportunity for health plans and pharmacists who want to offer and get paid for a higher degree of services. I do see that the ends of the spectrum coming closer and closer
yeah.
together.
Yeah, and another shout out, Maryland CPSN just won an award at NCPA's annual convention. So
Right.
we're making moves in different sectors, and it's just a matter of building that out. So I'll leave on that because that's a high note. So we'll end on that. But one thing that I always ask the people that I invite to come onto the podcast is also about themselves and what they do for self-care, because I think we all need to be taking care of ourselves. And nothing cannot be the answer. But really, I think it's just important as professionals, as we're trying to make policy changes, and we're doing big things in the world, and it's not easy. We're managing lots of different things in personal lives, and many of us are in that sandwich generation of parents and children, and career. And so just wanted to ask you, what do you do to make sure that you're taken care of? How do you take care of yourself?
Well, I think the first thing I would go to, because I think of hobbies when you say it, and I think I probably, the wine doesn't help. Watching Steelers games on the weekends, that's probably disadvantageous to my health. But I think of the things that actually, from a self-care perspective, I'm addicted to family.
Okay.
I've got a great wife and 4 kids. To me, that's my happy place. When I'm not doing drug pricing, that's pretty much it.
Okay, gotcha. Well, good. Glad to hear that. And always, there's always opportunity to span. And I don't want to tell people to switch teams, but but I will say the Steelers have always had Mike Tomlin has had a winning season every year, right? That he's coached. So
That's right, but we're
may
also
not
spoiled.
advance.
Yeah, so we're spoiled, right? Like they have
Yeah.
6 Super Bowls. I got to see 2 of them.
Okay.
I expect more. I'm also an Ohio State guy, right? So when
Okay.
they're not in the top 4, I'm like, well, this is worthless. What are we doing here? So so when you're spoiled like that, you're like, okay, well, if they don't win the Super Bowl, the whole season was a bust. So I don't have a very healthy relationship with sports because I need to
Okay.
have a more optimistic perspective than the pessimistic one I tend to reside in.
Gotcha. Thanks. I think that's a lot of the sports fans, how many of us feel at different times. So that could be appreciated.
I
Well,
bathe in negativity.
no, we're going to get some positivity. Well, I really want to thank you for coming on and sharing your perspectives. I think for our readers, our listeners, this has kind of opened their eyes, because a lot of us have been privy to your reports and information, but I don't think the sort of general, like our pharmacy association members, are really aware of all the details and the work that goes into the changes that we're attempting to make. So I appreciate all the work that you're doing, because we certainly benefit from it. We learn from it, and we're continuing to build and work to make a difference. So appreciate that. And I know you're very active on LinkedIn, and so we'll put your a link to your profile there in the episode notes. And if there's anything else you want to share, any last words with our listeners, I'll let you
No,
have that.
I'll just say, look, it's a very convoluted marketplace that pharmacists are sandwiched between. What we try to do is using data and an understanding of how the system works and how money flows through that system. We try to simplify it for the purposes of bridging that gap between misunderstanding and understanding. I believe that pharmacists provide immense value to the healthcare delivery system. I don't think we incentivize and reward them commensurate with that value. So I think that we can, if we can pull pharmacists out from this sandwich, right? That is living between a drug pricing transaction that people want to pay less and less for. The more that we better quantify and understand the value that they provide beyond just giving over the drug, right? I think the better equipped pharmacists are to actually take a step forward and up to become a way more treasured role and vital role of the healthcare delivery system than they already are today.
Well, thank you very much. And we'll end on that.
Thank you.
Mm-hmm. Thanks for watching, and please be sure to like, subscribe, and rate the podcast on all major podcast platforms. We look forward to dropping more great conversations, and of course, sponsorship opportunities are available. Just contact us at MPHA. Thanks.